accreditation also has been something that once it got organised and sorted out, the US was first, the Joint Commission, then Canada, then Australia, and then sort of it was slowly building up, as you see on the graph. I'm on page 9, top of page 9. And then suddenly it became very, very popular to have accreditation, starting in about, well, the 80s through to the early 90s. Denmark came relatively late. I think that was quite strategic and smart, because I think Denmark's quite full of strategic, smart people. Because what Denmark was able to do was piggyback, you know that idea? Piggyback on already systems that existed. So it didn't have to start somewhere at the beginning. And sometimes that can be quite useful. But maybe Carsten or Niels or somebody can answer me this question. Why did Denmark not pick up accreditation till later? Was it a political thing, or was it you were waiting for other people to make mistakes and then you could sort of learn from those mistakes?
Well, you have the answer.
Yeah.
I would say that Denmark had in the early 90s taken a number of initiatives, among those being very early with a national strategy for quality improvement.
Mm-hmm.
And that strategy, which was issued in 1993, that strategy was renewed over the years, and because of that strategy, we were already on a track of our own, and that took up the attention about quality. And then all the emerging accreditation initiatives came alongside us, and we watched them. And then there was an initiative by one of the counties, the Copenhagen Hospital Association, and another one down at the south of Jutland, the county there, and they took up separately initiatives about doing accreditation work locally.
Mm-hmm.
And these initiatives together inspired to develop a Danish model of accreditation instead of taking in foreign models. So you could say it was a stepwise procedure that actually formed the basis of how a Danish accreditation system could emerge in the beginning of the 2000s. So I think that the first initiatives about a total Danish model was taken in 2001, 2002. It was debated in the strategic forum of National Strategy for Quality Improvement. So it was a gradual process.
Maybe
probably you can compliment or correct me.
No, I will not correct you, but another component may be that healthcare in Denmark has been the province of local government or regional government. So, in order for this to become a national strategy, one of the local governments needs to take this up and propagate the idea to the other ones. And which actually happened.
For whatever reason of the unique history of Denmark in terms of quality improvement, Denmark came sort of later into the international accreditation family. But I suspect Denmark benefited from seeing other sort of models and then designed the Danish model to suit the Danish sort of health system.
Yeah, we actually did some active exploration about the possibilities. One of the earliest one was the Joint Commission, as I told you. The Canadian accreditation was also here doing quite a few talks about bringing their model, and then there was a British model coming in through to the south. So there was a lot of activity on finding where to go.
Yes. I remember.
Nothing was good enough, so we had to make our own.
Of course. But you would still get, like all health systems and all initiatives in health systems have some sort of benefit from what's happening in other places. For example, we're going to publish a book soon, are we not, on health reforms in 30 countries. And there's a chapter on Denmark in that book. So it is we learn from the international experience, even though the Denmark model is a specific model for Denmark. So accreditation is widespread, and so you're not alone, but the Danish model is, through ICAS, is unique, and it has its own mix of responses to how do you raise the standard and continuously improve healthcare and the delivery of services. So now I'll turn to some research. And really, we've done a lot of research. I don't know how many papers we've published. We've probably published 80 or 100 papers. We've done multiple studies on accreditation over the years. So I've just sampled some of those and thought about what do we know currently about accreditation. So I'm mostly basing this on the Australian data, but it's generalizable, I guess, to most countries and most health systems. So one benefit of accreditation is that having a positive accreditation result is associated with good organizational and clinical performance. So what that means is, if I can just illustrate on a diagram here, see this diagram here? I could even do that. No, I'll illustrate it this way. So say you're an organization which has good accreditation results compared to an organization that has poor accreditation results. So the surveyor's reports come in, the awards committee meets, and somebody makes a judgment. And say you're an organization with more positive feedback and good results. Is that related to anything that actually goes on inside the organization, like the quality of the care, or how well the organization functions? It should. It should. But does it? Well, that's an interesting question. In other words, do organizations just simply get good at passing accreditation, looking good for the surveyors, having good documentation, but actually they're not very good? It's a poisonous hospital, they provide terrible care, and they're horrible to each other, and there's a lot of bullying going on. I'm sure that doesn't happen in Denmark, but I know it does happen in some Australian hospitals. So that's an interesting question. That's an interesting question. And it's a question that sometimes gets asked in health systems. Does it not? In other words, does accreditation simply assess you, and if you're dressed nicely and have lovely policies and you can talk well to the surveyors, you get a tick of approval? Well, the answer in research that we did was no, there really is an association between things like the organizational culture, the quality of care delivered, measured by good clinical indicator analysis, and so on and so forth. So what is, in studies we've done, if you're this organization getting a good accreditation result versus these organizations getting poor accreditation results, that really is real. And it's associated with really three major things. The things it's associated with are a good culture, a culture that's positive, good leadership, the organization's generally well run, and good quality of care measured by clinical indicator performance of that hospital. I'm talking about hospitals here, not general practices or other healthcare organizations. So we ran a study. It's published in Quality and Safety in Healthcare. It's now BMJ Quality and Safety, where we published that data. So having the bullet point says having a positive accreditation result is associated with good organizational and clinical performance. Now let's assume you accept that as an argument, and let's assume, secondly, that it applies in Denmark. So let me ask you this question. Is it guaranteed? Is it guaranteed that if you get a good accreditation result, you've got a positive, receptive, productive organizational culture, and you're a well-led organization, and that you deliver good clinical care? What do you think?
Right?
Well, just out of a gut feeling, and then yes, there is a link. Yeah.
So, can I say, you saying to me, with all your silence, you hope there's a relationship, or you think there's a relationship? So my question back to you, with all your silence, as a researcher, is, shouldn't you know that? Shouldn't you have maybe either done or be planning to do in the future some research. So you can say to government or the stakeholders or the international community or whoever you want to talk to, we really know that accreditation makes a difference. That would be my hope for you in the future. Now, I know you can easily say back to me, I'm having a dialogue with myself in the absence of in your silence. You could easily say back to me, okay, but we're not a research organisation. We're just trying to do the best we can to deliver care, to stimulate care and to create standards and have them assessed and, you know, have a surveyor workforce and all the things that you do. I agree with that. I agree with that. You're a provider of accreditation services, if you like. However, the researcher in me says this to every organisation I encounter. Do you really know that you deliver results in exchange for your funding? I say this to every organisation I ever meet, including ministries of health and accreditation bodies, and so I'm not very popular sometimes across the world when I challenge people. Do they really deliver in exchange for their funding? Yes?
As we talked about before, you know that we have been doing interviews around in the regions in the months before the vacation time. And what we met, one of the many things we met at these interviews was that over and over again they said, basically we find it's a very good model. And that for both clinicians and quality people. So those people out there, they feel it works for them.
Yep.
But that's an information at the least about that they feel that it's worthwhile. So they feel the clinician level that comes something out of it.
Mm.
That's an information, though.
That is, and that's good positive feedback. If you're ICAS and you get this sort of feedback, you feel that maybe this is worthwhile. But I'm just saying, is there another step to go?
Yeah.
And I guess if you feel that, then you're like many, many other organisations across the world who are delivering accreditation services. That maybe we need to almost be sure that what we're doing is actually improving care. Sorry, somebody had a question?
Yeah, I was just thinking that we are doing the study about unknown, unannounced visits survey.
Yeah.
And that I think we do that because we are not sure that we
Correct.
are making a difference.
Correct.
Because we know from the experience that people know a hell of a long time before we are coming this week, and what can they do this week so they look nice.
Yeah.
So we know already that there's a problem there, and we
Yeah.
try to make a study about unannounced visits.
Yeah.
And see if we can have any results.
And I'm agreeing with you, and I'm just saying, over time, it's really good if you are working to demonstrate, to show the benefit that you deliver. It's a really useful thing to do.
If you ask me, I am fairly confident that accreditation is able as an assessment method to pick out the well-performing hospitals. Not that we in every case are doing it to the full potential of the method, but I think the method has the capacity to do so, which does not necessarily mean that participation in an does not prove at least that participation in an accreditation program is the best way to achieve this level of performance. And we suspect, and it's not merely based on our imagination, but also on a lot of anecdotal evidence from out there that is amazing, that some things are going on in the name of implementation of the accreditation program that probably will not lead to very much improvement of performance.
Yes.
And that's one of the things we are going to address in this project with unannounced visits.
Yes. I'll tell you the model in my head about accreditation, okay? So I worry that what happens with accreditation is this model. And there's no real improvement. What people are doing, though, is looking good in their performance every time they get accredited and going back to normal in between accreditation times. Okay? Now, if that's the model, then we're failing. Because people are just wearing a pretty dress or a nice suit every time the accreditors come along. And then the real improvement that they could be doing is passing them by. So instead of that model, what I hope instead is it's a model like this. Yes, you might be looking good every time the accreditors come along because you want to pass, you're desperate. Okay? But that generally there's an improvement cycle that means that everybody's improving over time. There still might be variation in performance, even pretty poor performance, but generally, as a cohort, the organisations in Denmark are improving over time. So I hope it's this model, and I think it is, but I'm worried that it might be that model, at least for some organisations. Okay? So that's what I'm sort of really keen. Sorry, I know I keep jumping around and you're trying to take this.
But we still have the possibility to do that now in Denmark, because it's still very early that the hospitals have taken accreditation, so we can still only do research in like cross-sectional part or some follow-up for 1 or 2 years. But we will do that.
Yes. Well, yeah, at some stage, but this is quite. Yeah. See, the other thing is, I said to Denmark before they acquired accreditation, and also Hong Kong, the two in the last 10 years, the two countries that didn't really have accreditation that got it was Hong Kong and Denmark. Okay, and I said to both of them, why don't you run a randomized trial? Why don't you divide all the hospitals up in your health system into 2 cohorts, randomly assigned, 1 into each cohort, give 1 accreditation, and the other one leave it as it is. Do some baseline measures and then assess it after 3 years. No one allowed me to do that. Why? Why wouldn't a government be in Hong Kong or Denmark? They're both very smart governments. Why did they say no? Why would they say no to that?
Because sometimes it's unethical to do that. Because if you really believe that accreditation is doing the difference, then you'll say that some hospitals or some patients, you'll have the really good quality. You'll have hospitals that perform good and are improving.
We had this discussion, didn't we? Because you say you want equity.
Yeah.
So you're willing, well, what happens if accreditation actually produces results that make things worse? So you want everybody to equitably have a worse outcome.
Yeah.
So equity is more important a driver than actually knowing whether the expenditure of money and patient care is better. It's an interesting paradigm. See, I'm a researcher. I keep always retreating to, where can I do research to absolutely know whether things are worthwhile? Interesting, huh?
But then again, in a study like that, it would be difficult to prevent contamination from one arm of the study to the other.
Of course it would be.
Yeah.
Of course it would be. Of course it would be. It's not like patients where you can keep them separate from each other.
No.
Everybody in Denmark, especially a country like Denmark, everybody would know that I've been randomized in and I've been randomized out. So it wouldn't be a perfect randomized trial, but it would be better than nothing at all. Anyway, you can't unscramble the eggs. Nobody in Denmark or Hong Kong wanted to buy that, even though I suggested it to both of them. So I'm the failure that you see before you today. Niels?
I think there's another issue about the improvement through accreditation. That is, if we didn't have the accreditation, how would the improvement have gone by itself, so to say? You can never disentangle this. So how can you take out all the other improvement thing and say this is due to accreditation work and this is due to general improvement work? So that's another issue that we are being confronted with as working with accreditation.
I agree. You could, of course, yes, I mean, we could have an argument about this, but you could, of course, take indicators, baseline indicators, that really do map to whether you get accreditation or not. But yes, these are the difficult studies you're suggesting, and I agree with you.
So there was a basic problem there in saying that accreditation does it good.
Yeah. But the basic reason is twofold. One is because, as you say, you need to give things in doses equitably across the whole health system. And the second thing is politicians wouldn't like this. Politicians wouldn't like that.
And another thing perhaps related to something we heard at Hinscout at the Resilience Conference, we are not striving to finding the best way to improve a national healthcare system. We are trying to find a way that works, that's not too expensive, and doesn't have too many side effects.
Yeah. So that was just a diversion. I should get back to my slides, should I not?